Welcome to CR Arthritis 2025. My name is Ellen, and I'm the Programs Coordinator at Arthritis Consumer Experts. Today, I'm joined by Deborah Marshall. Dr. Deborah Marshall is a professor at the Cumming School of Medicine in the Department of Community Health Sciences at the University of Calgary. Dr. Marshall is a health economist and a health services researcher leading a program of applied research using patient preferences, patient engagement, and simulation modeling methods. And we will get into exactly what that means. Dr. Marshall is also presenting both a workshop and a poster on the Ucan, Can Do, and Cure International Perspective Study. And with that, Dr. Marshall, welcome to our program.
Thank you. And thank you, Ellen, for the introduction. Very happy to be here. And thank you to the Arthritis Consumers Experts and Arthritis Research Canada for hosting this. As you mentioned, I am a health economist, but in the intro, you probably heard a lot of patient, because maybe unlike a lot of health economists, I actually do a lot of work with patients. And part of what we've done in the Ucan, Can Do, Cure, and that stands for Understanding Childhood Arthritis Network. Can Do is Canada Dutch. And then cure is about the idea, it's not an acronym, it's actually cure, like looking for the cure for childhood arthritis. So that's what those programs are. And this is funded both through CIHR, Genome Canada, Genome Ontario, as well as Roma Funds and Zona and Bay in the Netherlands. So this is a multi-sourced partnership program. So we're very excited about that program. We have one of the largest cohorts in JIA. It involves every single pediatric rheumatology center in Canada and the Netherlands. So yeah, exactly. I saw your face, Alan. We're pretty excited about that, but more excited about what we can potentially learn from this. So yes, this is a biology-based program of precision medicine. And we also have integrated a substantial program of health economics, which includes simulation modeling. So looking at what would be the impact and effects of different kinds of treatment patterns for patients of different types of JIA, juvenile idiopathic arthritis. And we also are looking at patient preferences for starting treatment, for tapering treatment, as well as doing embedded research on patient-reported outcomes, as well as working and to look at what the burdens and the costs are. So we have been focusing in these two presentations that you mentioned at CRA at what is the burden of illness. And I really don't like that terminology, but in the literature, that's what we use. Trying to understand the broader costs to patients and families, both from a work productivity, a daily activities, and also out-of-pocket costs. And those, I think, are the things we're going to talk about in a little more depth. But the whole point of this, just so people appreciate it, is to really try to understand the impacts of childhood arthritis. We are still living in an era where a lot of people don't know that children actually get arthritis to begin with. So this research is really trying to highlight the impacts to the children with arthritis and the broader impact to their families and the communities and actually even our economy, right? If you think about work productivity and things. So that's really what the work is aimed at. And we do this in partnership, actually, with patients. One of our patient and community engagement research cohorts that were trained here at the University of Calgary and graduated with their certificate in patient engagement research, published a paper on transitions, and I'll talk about that a little bit later. But they have continued in various forms to be involved in our research program. And this really brings reality and life to the work we do. And that's probably the part I enjoy the most about our research. And a couple of them are here at the CRA. So we'll be seeing them in the next few days.
Very exciting presentation. And, I'm just, again, taken back by the level of collaboration and how large this cohort study is. And for our audience, a cohort study is where we gather individuals who have, in this case, juvenile arthritis, different types, of course, and we follow them over a significant period of time. And these projects are usually, let me know if I'm wrong. You are the economist, quite expensive. But if we do them right, they can give us so much information because of the longevity of the project, because of the layers that we're able to unravel through that time of understanding. As you noted, the word burden I don't like, but the broader implications. So just an incredible collaboration, an incredibly large project.
Yes, yeah, we have one of the largest cohorts of JIA patients that so well characterized is what I'd say. And just so people understand, they don't all start at the same point in time. This is actually a cohort such that we have people who may have just been diagnosed, who may not yet be treated. And we have people who are on different treatment regimens. And then we also have people who have been on treatments for a while, who may be considering tapering and reducing their dosages, or maybe stopping treatment if they're stable and have controlled disease, inactive disease. So we have people across all the different sort of stages of the disease cycle. So that makes it interesting. And we have both a lot of laboratory measures that we've collected on them, as well as information from surveys, like the costs that have been incurred by the families, yeah, and the impacts.
I know you're presenting a workshop on how juvenile idiopathic arthritis affects employment and usual activities of adolescents in this case. Specifically, what are some of the key messages, some of the key takeaways from that presentation?
Yeah, first of all, I'd say one of the things that's quite remarkable is this is actually one of the first studies to look at how JIA impacts work productivity and daily activities amongst youth. So we're focusing in this particular presentation around youth who are of working age. So it's sort of the 16 to 18-year-olds where they would be more likely to be employed. So this is the subgroup of that. And the key point about this is we're using a standardized instrument, which is called the WPAI, which is the Work Productivity and Activity Index. And it's important to use a standardized instrument because then it's got a validated result that can be compared to other diseases and other things, and give us rigorous data that can be presented to either researchers, policymakers, whomever your audience is. So that's quite an important aspect of this. So we, in the WPAI, as it's called, you're able to measure both work productivity, which we call presenteeism. So you're at work, but you may not be at top performance, as well as absenteeism, i.e. you don't go to work. And then also, it looks at the idea of usual activities. So have you refrained from doing sports or even household daily chores because you are feeling pain? So has your normal daily activities been hampered or impaired in some ways? So it's kind of nice because you get that overall sense of work productivity as well as this daily activities, the usual activities. Okay. And so what we found is actually the whole work impairment aspect of this, or the work productivity aspect, is up to 30%. So on average, 30% work productivity impact for patients with JIA. Yeah, it's actually substantial, right? This 1 out of 3, right, days that are impacted. And then the other thing is that with their usual activities, it's actually very similar. I think it's like 28%, 29%, 29% impairment in their usual activities. So that's a lot. And you think of young people who are usually very active and they're putting a lot into their day. And you also think of them who are being new on their job, right? And so there's already enough maybe stress. Don't want to impose that word, but at some point there's a lot of change because they're learning a new job, and so you have some anxiety about this, and then you're not feeling well, you're in pain, and you can't function at your optimal perspective. So this is really quite important to be able to tell this message. And I'll just go back to what I said earlier. This is the first study to examine JIA impacts on work productivity and usual activities. So we want to bring evidence to decision making. And I think at the moment, people outside of, people who are rheumatologists and patients, obviously, and their families, so people understand that there really is a large negative impact of this disease. And it also affects people's choices about what they can do and what they can't do. So we have to bring this evidence into the discussion and considerations about how we support families and patients in the future.
Oh, absolutely. And, reflecting on my own experiences and me getting my inflammatory arthritis diagnosis pretty early in my life, those were the most formative years of my life. My first jobs made me who I am, right? Like, I still remember my first job. Those were like truly like some of the best experiences to this day. And I just like 30%, like that is not like, oh, that's just clinically significant. No, 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 that's very relevant. That is, I just find it so interesting. One was 30% and one was 29%. So there must be something there. If the evidence is showing a very similar number on both sides of that measure, it's probably pretty good. And like you said, like the next steps of now we have to take this information to advocate for what we can and must do to
Yeah.
support patients and their families.
Yeah, and to your point too, that's an average, okay? So it's already, you kind of go, wow, that's a lot. But we also found with this that it depends on disease activity level. So, people who have a higher disease activity level, not surprisingly, have higher impairment. So when we're talking about moderate and high disease activity, we're talking 45, 43% activity impairment and work impairment. I'm going to round, like half. That's a lot, 50%. Okay, and it's rounding up a little bit. Nonetheless, you get the idea. It's a big number. And yeah, it affects people adversely.
And your poster presentation looks at JIA and out-of-pocket costs for medical and other health professional visits. Could you, again, share some of the key findings from this poster presentation?
Absolutely. So again, what's nice here is we were able to collect data on out-of-pocket costs. And now not everybody has out-of-pocket costs. So in the people who do, though, what we find is an average of $866, okay? And this is an annual out-of-pocket cost. Then what's really notable too is there's this range of $8, so a small amount, okay, all the way up to $10,000 in a year. So if you think about this and you think of the impact on a family, those are out-of-pocket costs, those after-tax dollars. And it's quite a lot of money that they have to pay, as the term in health economics is framed, out of pocket, right? It's not covered by insurance. It's not covered by private or medical insurance, and they have to supplement essentially those expensive with their own private resources. So in health economics parlance, that's opportunity cost, and it means they can't spend that money on other things for the family or for the child. So what's included in this is things like traveling to the medical appointments. So there's a lot of physician visits and a lot of visits, for instance, to other kind of health professionals like physiotherapists or occupational therapists, orthodontists. So they often have trouble with their joints in their jaws. So orthodontists, psychologists. There's a lot of depression in children with JIA because they're in pain and they're not able to move and, well, be a kid and do all the things their friends do all the time, right? So that's those are the kinds of things that are involved with the costs. And I think the other thing around this to think about is a lot of specialists. So they go to see, pediatric rheumatologists. A lot of the specialists are in urban centers. So it also raises, and we don't have the data for this, but we're going to investigate this further. It also has implications for equity, right? So what are the implications of people in rural areas who are traveling longer distances and it's harder to get to the specialists, et cetera? So this is something very important to think about, especially in a country like Canada where, people live sometimes quite far away from the urban center. So this also raises that question for further exploration and understanding those distributions amongst different people and families.
Yeah, it because when we think about like the value that you provided us, right? Versus like when we say this is the average, that doesn't mean that this is what people have. Like it is like a spread, like you said, $8 to $10,000. But it really does make sense when you think about, for example, if I'm a parent and I'm driving my child to an appointment, right? And I may be living in a rural area. That is the entire day gone from driving. I just took the day off work, right? Because I'm going to be there to support my child. So those are the costs we don't necessarily think about, but your work will be able to tell us so much more about these costs, and looking forward to learning more about what you find in terms of these geographic differences.
Yeah, we are too. And it also sort of segues a bit into the work. One of the Canada First Research Excellent Fund, we were honored to be one of the awardees of these programs. It's called One Child, Every Child. And it's one of the things that we're challenged with in that kind of research grant is to say, well, what's the impact on the economy of Canada, right? Well, you just described it, Ellen, and that is, gee, it's not only the child. And yes, there's these impacts on their work, their potential future educational opportunities, career opportunities, but their parents, because their parent also isn't at work. And we also have another presentation on the parent work productivity loss as well, but that's a separate one. But it's also substantial. Spoiler alert, you'd be surprised. So this does affect our economy because now we have, two people at least, if you're driving a working age child to an appointment and all this, who aren't able to be at their work.
It gives us so much to think about. I think your project really is just like there's so much to think about, and there would be so much interesting data that comes out of it to then explore new questions. But as a patient or perhaps a family member that's listening, do you have any insights you can share to improve a patient, in this case, an individual with juvenile arthritis, their self-care or their disease journey, or how they can self-advocate?
Yeah, absolutely. One of the things that I really enjoyed, we had a panel presentation at our Childhood and Arthritis Beyond conference last May, and this was organized by Cassie and Friends and with support from the Arthritis Society as well. And we had a large number of families there. And one of the things that I really enjoyed was sharing some of these preliminary results with patients and families, and they were involved in this. And talking to them about, well, what does this mean? What does this translate to? And one of the things we've learned, both from that discussion, but in qualitative research that we've done that complements this, is around the idea of, how do you support, particularly in this transition period for youth when they're entering workforces or going into their last years of school and thinking about going to university or some other college work or applied kind of training. The key importance of equipping, I guess, our youth and our young people about how to advocate for themselves. So, for example, getting accommodation supports in the workplace. So even though it might be uncomfortable and maybe there's some stigma associated with saying that, you do have this condition, it can really help, because if an employer knows that there are issues and that there is a need for accommodations, it really helps for them to be aware. Sometimes there are programs that can help, with training. There might be different accommodations, just even in the ergonomics of how a workstation, whatever kind of work you're doing, is set up, or in the way break times are given, or in the exact type of work that you do. Maybe there's some parts of it maybe you don't do, particularly if it's a physical kind of job or it has parts of it. So even just knowing that and feeling comfortable to be able to say that, and being supported by your family and also by the community, and for workplace and employers to be cognizant that this is real, and to try to help as best as they can to enable, is really important. So, and then the family and friends really, again, being aware and providing social support, because it's really hard for children and families where sometimes they just can't participate. And it's not because they're antisocial, they just can't. And they want to, and they already feel badly enough. So I think just being aware and understanding, and sort of appreciating that that's their situation, really makes a big difference.
Oh, absolutely. And it has to start young.
Yes.
I've learned anything about self-advocacy is it's a skill that you practice, right? It's a muscle. It's just like when you go and to the gym and you practice an exercise, you have to practice. Otherwise, it's very uncomfortable to advocate for yourself. But it's very important to do so. It's a skill that you need to own. It's something that you're going to use for the rest of your life, whether you have, arguably whether you have arthritis or not. So the fact that you're starting so young is just like that really hits home for me.
Yeah. And by the way, for instance, at that meeting, and it's sort of heartbreaking, but kids can be diagnosed literally when they're two, or even younger, but it's harder, of course, to diagnose because there maybe isn't so much communication between a baby and the mother. The mother knows something's wrong, but they don't know what it is, and it's not always obvious. So, yeah, it starts early. And so one of the things we also learned at that conference was being aware, for parents also to be aware that if they're observing something unusual, that there may in fact be something unusual in their joints. But parents don't, I mean, why would you immediately think, oh, my child has arthritis? It is not something you would automatically think about. So the more we can spread the word and make people understand that this is real, and that it really has a substantial impact, and it's not made up, and they really are in substantial pain, which is causing it to be very difficult to do some things, then I think the better it is. And most people really want to help, right? But they just don't necessarily know.
A very, very powerful message, Dr. Marshall. And I hope everyone else got to learn as much as I did from that conversation. Thank you for spending time with us right before the CRA meeting. And thank you for our audience for tuning in. We highly encourage everyone to check out all the episodes from CR Arthritis 2025. And with that, we wish you a wonderful rest of the week. And we'll say goodbye for now.